Hello, I am Dr. Peter Chang. I am a pediatric ophthalmologist practicing in Miami, Florida. I have been asked to speak to you by the Sturge-Weber Foundation about Sturge-Weber syndrome and the eye. Today's date is June 14th, 2021, and it is important to remember that as new clinical evidence develops, some of what I'm going to tell you might become outdated. This talk is meant for patients, families, and friends of those affected by Sturge-Weber syndrome. Here are my financial disclosures, none of which pertain to the content of this talk. So there are also other disclosures. It is always important to know that there are many ways to treat the same disease, and there are many reasonable variations. And what I'm going to tell you today, very few items have high quality clinical evidence in terms of Sturge-Weber syndrome related eye disease management. So we will break this short lecture up into three major parts. In the first part, we will go over ocular anatomy, aqueous humor physiology, and talk about the prerequisites for vision to occur. In the second part, we will focus in on Sturge-Weber syndrome and the eye, namely the pathophysiology, presentation, and management of eye diseases related to Sturge-Weber syndrome. And in the third and final part, we will take a broader view and talk about the doctor and the patient in terms of visual development, what happens when the child gets glaucoma, and the importance of clinical surveillance. So in order to understand how Sturge-Weber syndrome affects the eye, we have to all agree on the proper terminology for the structures in the eye. Here is a color photograph of the right eye. And first we have the upper and lower eyelid, and here's the lid crease. And of course we have the eyelashes. In the upper outer corner, underneath the skin that covers the eye, sits a lacrimal gland. Similar to a sweat gland, this is the gland that secretes tears, which then bathes the surface of the eye to allow it to stay moist. The inner and outer corners of the eye are called the medial and lateral canthi, or medial canthus and lateral canthus. And near the medial canthus, there are two tiny openings along the lid edges that are called the puncta. That's where the tears go to exit the surface of the eye. The white part of the eye has two layers. The deep layer is called the sclera. The superficial layer, which is a clear membrane that covers the sclera, is the conjunctiva. The color part of the eye is covered by a clear dome called the cornea, and the actual colored tissue inside of the eye is the iris. And the pupil is the space formed by the iris, similar to the donut hole formed by the donut. Between the cornea and the iris is a space called the anterior chamber. And behind the iris, there's an organ called the crystalline lens, which helps the eye focus light. Behind the lens is a space called the posterior chamber. Most of the eye is filled by a substance called the vitreous, and the vitreous has a consistency similar to uncooked egg white. The fovea is the portion of the retina where light focuses and allows the most fine vision to occur. And all the information from the retina and the back of the eye is brought to the optic disc, where the visual information is then turned into electrical signals and sent to the brain. And the cable that connects the eye to the brain is called the optic nerve. In more detail, the fine tissue that lines the back of the eye, similar to the film inside an old-style camera, is called the retina. And behind the retina is a layer of very vascular tissue called the choroid. And this tissue is very important when we discuss Sturge-Weber syndrome and related eye diseases. So what are the prerequisites for vision? It is important to remember that vision is acquired, not innate. And a useful analogy is to think about language. Most babies are not born able to speak or understand speech, but over time, with adequate hearing, they acquire the ability to speak and understand speech. Similarly, most babies do not have the ability to interpret visual signal, but if they have an intact visual system, they then acquire vision. For vision to occur, light has to be present, and it bounces off objects and enters the eye and is focused on the retina. Retina then converts this light signal into electric signal, and this signal is then sent to the optic disc and then travel through the optic nerve to the part of the brain called the lateral genicular nuclei. And then this information is further sent back to the visual cortex, which then interprets the visual input. When we talk about the ocular manifestations of Sturge-Weber syndromes, we can break these up into two large groups: diseases that affect the outside of the globe, namely the eyelid, the eye socket or the orbit, and the brain, and those that affect the inside of the eyeball. It is easy to think about the diseases in three major groups. Amblyopia is when the brain did not learn to use the eye. So recall the previous slides when we talk about vision being something that is acquired, and amblyopia occurs when the brain fails to acquire or develop vision. The problem with the eye, so-called eye issues, that's when the eyeball is not working and the camera is broken. And lastly, brain issues, when the brain is not able to interpret visual signals. So first we'll talk about entities that affect the eyelid and the orbit. So in the inset is a photograph of a patient with a large hemangioma on the eyelid, causing the eyelid to be a little bit droopy. And this drooping of the eyelid can cover the pathway of light, causing light to not enter the eye properly. And it can also cause a warping of the surface of the eye, causing light to become distorted as it enters the eye. And both of these things can cause amblyopia. So what is amblyopia? It is the official term for what we sometimes call lazy eye. It is poor visual development at the brain level. As we have discussed earlier, vision is acquired, and when light focuses differently between the two eyes, the eye with a worse focus can sometimes get turned off during development. And supposedly 2% of all people have amblyopia from all different causes, not just due to Sturge-Weber syndrome. And so amblyopia is actually not uncommon in the general population. When light focuses poorly in both eyes, vision does not develop fully in both eyes. And the window of vulnerability for amblyopia is between the age of 0 to 6 years. Switching gears a little bit, let's talk about how Sturge-Weber syndrome affects the inside of the eye, namely how it affects the outflow system, the retina, and the choroid. The eye maintains its pressure by secreting aqueous humor, which is a clear fluid that is constantly being produced and drained away from the inside of the eye. Aqueous is produced by the ciliary body, which lies behind the iris, and it trickles around the lens through the pupil and fills the anterior chamber, and finally is drained away by the trabecular meshwork. From there, it flows downstream through the episcleral veins and the superior ophthalmic vein back into the venous circulation of the body. And it is at this step where the pressure can become high in Sturge-Weber syndrome, because when there is a hemangioma affecting the surface of the eye or in the eye socket, the episcleral venous system and the superior ophthalmic veins do not work properly, and pressure can build up inside the eye. When there is outflow obstruction and aqueous is being produced, the pressure inside the eye becomes high. And in the front part of the eye, this causes the clear dome, the cornea, to swell up. It can also stretch the cornea such that the diameter increases, and it can cause stretch marks on the cornea, what's called Hobb striae. And all these things can lead to scarring of the cornea, erosion, and ulceration. When the cornea is affected, light can no longer enter the eye undistorted. In the middle of the eye, increased pressure can stretch out the entire eyeball, causing worsening of nearsightedness. And this stretching of the ciliary body to which the lens is attached can cause the lens to become dislocated. And this can also cause a thinning of the sclera, which is the eye wall. And these can lead to strabismus, which is misalignment of the eye due to abnormal attachment of the extraocular muscles, and retinal detachment when the inner lining of the eye detaches. Lastly, this increase in pressure can cause progressive damage to the optic nerve, which is manifested as the increasing size of the optic cup. And this, of course, leads to glaucomatous optic neuropathy. In addition to these ways where intraocular pressure elevation can cause a decrease in vision, amblyopia, or the failure for vision to develop properly, also plays a major role in further hindering good vision in these patients. So how do we classify glaucoma that is associated with Sturge-Weber syndrome? This all came from a concerted effort by the Childhood Glaucoma Research Network, which is headquartered at my home institution, the Bascom Eye Institute. And this consists of the international consortium of pediatric glaucoma specialists, where we came up with a classification system for the purpose of research and clinical care. And this is a very extensive classification scheme of childhood glaucoma. And glaucoma associated with Sturge-Weber syndrome really falls into the box that is highlighted: glaucoma associated with non-acquired systemic disease or syndrome. This is what corneal edema looks like. The eye becomes hazy, and corneal edema can be very painful. And so frequently we see the child having a lot of light sensitivity and tearing. In fact, one of the classic presentations of childhood glaucoma from any cause, not just Sturge-Weber, but from any cause, is what we call a triad of epiphora, which is a fancy way of saying tearing when the child is not crying, photophobia, which is light sensitivity, and blepharospasm, squeezing of the eye, inability to open the eyes. I often teach my students that when you see a baby in the clinic and they have a combination of these three findings, the most important thing is to make sure that we're not missing glaucoma. The eye can stretch out and increase in size, such as in this set of photographs, where the left eye is much larger than the right eye, presumably due to a history of high pressure in childhood. And we have fairly specific criteria as to what constitutes an increased corneal diameter. So looking at the further back of the eye, we need to talk about a few structures in detail. We had previously covered all these findings. Now we're going to talk about specifically the retina and the choroid. So retinal detachment is when the thin, clear membrane on the inner lining of the eye becomes detached. This is painless and visually threatening. The retina is the tissue that is responsible for turning light energy into electrical signals that our brain can perceive. So when the retina becomes detached, the eye no longer has the ability of converting light to electrical signal, and the eye can become blind. The retina is attached to the inside of the eye, very much like wallpaper is attached to a wall, and it can peel off of the inside of the eye, very much like how wallpaper can fall off of a wall. This is sometimes very difficult to detect in young children, and when the choroid, which is the dry wall on which the retina is attached, has any dysfunction, retinal detachment can happen much more readily. Unfortunately, when retinal detachment occurs in Sturge-Weber syndrome, there is really no effective treatment. Everything we do for these young patients on many fronts are experimental, and the outcome is uncertain. Here's an example of a young child with Sturge-Weber syndrome, glaucoma, and choroidal thickening. And in 2014, he had a normal looking back of the eye. Then in 2019, without warning, his choroid expanded and became much more swollen, and the retina over it, this corrugated scallop looking tissue, became detached. And after multiple efforts, including external beam radiation to resolve some of the swelling of the choroid became much smaller, but the retina remains detached. And this can happen without warning. Usually for amblyopia therapy, the two most important items are glasses and patching therapy. Glasses are needed because it neutralizes refractive error and help light to stay focused into the eye. And when glasses is prescribed to a child, the glasses is meant to be worn constantly from the moment the child wakes up until the moment the child goes to sleep, taking it off only during bath time. And this may need to be updated quite frequently, sometimes every 3 to 6 months, depends on the growth of the eye. And the glasses, in addition to focusing light on the affected eye, also helps to protect the better seeing eye from injury. Patching therapy is important because by patching the better seeing eye, you force the brain to spend more time with the weakened eye and hopefully improve vision that way. And the doctor may prescribe patching in the interval of anywhere between 2 to 6 hours a day. And we decided that patching has reached its endpoint if the vision fails to improve over approximately 9 to 12 months of trial. Patching can improve vision in an eye with amblyopia up to about age 12 or so, sometimes even older. And it is inexpensive, non-invasive, although compliance can sometimes be an issue. And we always want to use the skin patch instead of the pirate patch or the patch that goes over glasses. And patching should be done at home under the supervision of parents. So as you can see here, the picture on the left is a child using arm splints. These can be very effective in a child who cannot tolerate patching so that it prevents them from removing the patch and the glasses. The picture on the top is a child with a skin patch, which is the most effective way in treating amblyopia. The girl at the bottom with the pirate patch and the patch that slides over glasses. These tend not to be very effective because the child can peek around the patch very easily if it's not stuck to the skin, and it can fool the parents and caretaker into thinking that patching is being done when the child is cheating. And patching at school is often ineffective because the teachers at school really has very little incentive to keep the child patched if they were to take it off. And so I strongly advocate that patching be done at home under the direct supervision of parents or guardians. If a child were to develop glaucoma, the first line of treatment is usually glaucoma eye drops. These can be very effective in lowering eye pressure, sometimes for years to decades, and prevent the eye from acquiring more glaucoma damage. And it is very important to learn the medication's name, both brand name and generic name, and the cap colors. These medications are usually color-coded to allow both the patient and doctor to sort out which medication needs to be used when. It's very important to always clarify the correct dose for the correct eye at the correct time, and consistency is key. Sometimes patients will stop medication on their own or before a visit to the doctor to see if the pressure is automatically better. And this is not recommended because when the eye drop is discontinued, the pressure will go back up. And if this were done right before a visit, it becomes very difficult for the doctor to figure out whether the pressure is uncontrolled because of not using the eye drop earlier that day, or if the medication has lost its general effectiveness. So always use the medication and don't stop without the doctor's explicit instructions. If there are side effects that we think might be attributed to the medication, it is always a good idea to let the doctor know and get instructions instead of just stopping the medications. So clinical surveillance in young children with Sturge-Weber affecting the upper and lower eyelid. And if they do not have glaucoma, usually they are seen every 3 to 6 months in clinic for pressure checks. And if pressure remains normal, they get seen at the same interval until they're older. If the pressure becomes high, or if there are any findings in the clinic that makes them suspicious as having glaucoma, then usually an examination under anesthesia is required, where the child is sedated in the operating room and a full detailed examination is performed to sort out whether glaucoma is present. If the child already has glaucoma, then they are examined every 2 to 3 months in clinic, and we do an exam under anesthesia every 4 to 6 months. In older children, the timing is more variable depending on the maturity and verbal skills of the child. So, in summary, here are the key points to remember. Vision is acquired, it is not innate, similar to language. When we deal with Sturge-Weber syndrome in the eye, the 3 things we deal with are amblyopia, the so-called lazy eye or poor development of vision. We deal with glaucoma, which is damage to the structures inside of the eye due to high pressure, and retinal detachment, which is when the retina becomes detached due to poor choroidal function. We manage amblyopia by putting the child in glasses and by prescribing patching of the stronger eye to strengthen the weak eye. Glaucoma most often is treated with eye drops first and surgery if eye drop is insufficient in controlling the glaucoma. And as far as retinal detachment, there are no great treatment right now. We can simply put the child under surveillance and detect retinal detachment as soon as possible. Thank you for your attention.